My name's Alicia Judkins, and my case study is on pulmonary embolism. The patient is a 62-year-old female with a medical history of asthma. She had been diagnosed with a pulmonary embolism and a deep vein thrombosis 13 years ago. She was then treated with warfarin and was later discharged, followed up by regular appointments in an outpatient clinic. She was also diagnosed with asthma, which was controlled by long-term medications. Her presenting symptoms: she was brought to the ER for a week-long symptom of shortness of breath, which was assumed to be caused by her asthma. After a physical examination, she showed tachycardia at 101 beats per minute, hypertension with a blood pressure of 173/104, and her body temperature was 37.4 degrees Celsius, which is roughly 99 degrees Fahrenheit, so slightly elevated temperature, but nothing to be concerned about. Her D-dimer level was 2.64, and her troponin level was within the normal range. She had an echocardiogram, which revealed sinus tachycardia, and S1Q3T3 pattern was recorded. No abnormal findings were obtained in her chest x-ray, but her CT angiogram revealed thrombosis in bilateral pulmonary arteries, which corresponds to a massive pulmonary embolism. So what is a pulmonary embolism? It's the blockage of one or more of the pulmonary arteries in the lungs. This is the pulmonary circulation system. A little about the origin and development. A PE typically starts with blood clots. A thrombus is a blood clot that occurs inside a blood vessel. A deep vein thrombosis, or DVT, occurs when a blood clot forms in a deep vein. An embolus is when part of the thrombus breaks free and enters the circulatory system. So the picture on the left, you can see normal blood flow in the leg. The middle picture shows a deep vein thrombosis, so you can see that clot forming on the side. And then in the last picture, you can see the embolus breaking free. The pulmonary embolism process is the DVT or blood clot is formed, the embolus breaks free, it then enters the circulatory system and lodges in a pulmonary artery, which prevents blood flow and impairs oxygen exchange, and therefore lung tissue is damaged. Other PE causing substances are fat from the marrow of a broken long bone, collagen, tumor fragments, or air bubbles. Common signs and symptoms are shortness of breath that appears suddenly and worsens with exertion. Our patient showed this, but again, she had asthma. Chest pain that worsens with deep breathing, coughing, eating, bending, or pain with exertion that does not go away with rest, and chronic cough that may produce bloody sputum. These symptoms can vary greatly and are, for the most part, non-specific, earning PE the nickname the Great Masquerader. Non-specific means that it can be present in many other conditions. Other signs and symptoms are lower leg pain or swelling, clammy or discolored skin, fever, excessive sweating, rapid or irregular heartbeat, and lightheadedness or dizziness. You can see the swelling and red color in this deep vein thrombosis leg. It can be asymptomatic. Approximately 25% of people with a PE may experience sudden death without any prior symptoms. The picture is of a saddle PE, which occurs at the pulmonary vein bifurcation, and that is typically what causes the sudden death. Risk factors are a medical history of venous blood clots, pulmonary embolism, heart disease, or chemotherapy. Our patient had a history of both the blood clots and the PE. Other risk factors are prolonged immobility due to illness, surgery, bed rest, or travel, smoking, especially when other risk factors are involved, supplemental estrogen, which are birth control pills and hormone replacement therapy. It increases blood clotting. Pregnancy, as the baby creates pressure on the pelvis veins. Prevention is the best form of health care. Anticoagulants such as warfarin or heparin can help prevent the blood from clotting. Compression, such as pneumatic compression and compression socks. Physical activity, such as pumping your legs or getting up and walking around after prolonged amounts of time of sitting. Leg elevation and hydration. The diagnostic process, it starts with trying to rule out other pathologies with similar conditions first. So these tests are used to rule out other pathologies. So blood tests, D-dimer is a substance that is released when the clot breaks up. High levels indicate high chance of clots. Blood oxygen levels are low levels indicate a possible PE. And a clotting disorder, high vitamin K in the blood makes the blood clot easier. A chest x-ray is also used to rule out a PE, as a PE often appears normal, or a chest x-ray often appears normal when a PE is present, but it is a requirement before having a VQ scan. A ultrasound duplex scan is another test used to rule out a PE. It's checking for blood clots in the veins. If there are no clots, then there's a decreased chance of a DVT and therefore a decreased chance of a PE. If there are clots, then it may indicate an increased chance of a PE. Tests to diagnose are VQ scans, which are done in Nuke Med. A CT angiogram done with contrast, which our patient had. This is a CT of our patient, and you can see the clot there. A pulmonary angiogram can also be used to diagnose. It is a very effective way to diagnose, but it also has the most risk to the patient and requires the most skill. Prompt treatment is crucial. The treatments include thrombolysis, which is generally accepted as the first line of defense. Clot busters can be administered intravenously, and it's most beneficial if given 1 to 2 days after the embolism occurs. Bleeding is the primary concern, as it does reduce the ability for blood to clot. Thrombectomy is where they go up through a large vein and remove the clot with a wire basket. It's often followed by a stent. And a surgical pulmonary embolectomy is usually reserved for the treatment of high risk and immediate risk PE patients, as it does require open heart surgery. Typically that is done for those saddle pulmonary embolisms. 30% of untreated patients die, while only 8% succumb with effective therapy. For our patient, rivaroxaban was administered, but her symptoms did not improve. Therefore, she received a catheter-directed thrombolytic therapy by echosonic endovascular system. The symptoms thereafter were relieved. Follow-up pulmonary artery angiography showed decreased thrombus burden, as well as a drop in the pulmonary arterial pressure from 68 millimeters of mercury to 40 millimeters of mercury. The patient was then discharged under long-term medication of rivaroxaban. And here are my references.